Let's switch on our cameras, presenters, please.
Good afternoon, colleagues. Thank you for joining the webinar. We're just waiting for colleagues to join and then we will start. You're in the right place for the Good day, colleagues. Welcome to this very special webinar on behalf of the WHO Collaborating Centre for the Family of International Classifications based at the South African Medical Research Council. Especially welcome to the speakers who have agreed to participate and contribute to this webinar. I'm Lynn Hanmer. I'm one of the co-heads of the FIC Collaborating Centre. This is a very special webinar. It marks the 25th anniversary of the inclusion of the ICF, well known to many of you on this call, in the WHO Family of International Classifications, or the FIC, as we call it. It's really fitting that this CC, our CC, is doing this today. One of the two important strands of work in the CC and preceding the CC was indeed in ICF and in functioning coding more generally through our colleague Jennifer Jelsma, who was part of this initiative many years ago and then continued after the development or the designation of RCC in 2012. We also have in our CC here one of the co-chairs of the FIC FDRG, the Functioning and Development Reference Group, Soraya Mart, and she's going to be leading the seminar, this webinar this afternoon. So we have a very full program. We're going to flash up very quickly the housekeeping. Please do just note it, usual housekeeping for a webinar. And we'll show you then our order of business for the afternoon. We are privileged to have colleagues from a wide variety of backgrounds and areas of work. And without any further ado, I'm going to hand over to you, Soraya. Thank you.
Thank you, Lynn, and welcome, colleagues, as Lynn said, to this auspicious occasion where we celebrate the inception and development of the International Classification of Functioning, Disability and Health that provided us with a key and a change in understanding of disability and impairment, disability and functioning. As Lynn had said, South Africa has been in the forefront of the development of the ICF as well as in its maintenance through the updating platform on which I serve as well as Stefana serves. So we've played a crucial role in the development and maintenance of the ICF. For years, we have published in the ICF. We more from a conceptual framework using the biopsychosocial approach. But today it's about how are we expanding the use of the ICF. The ICF has moved from just being a conceptual, theoretical framework to now being a coding tool and available on the WHO website and available to countries to use within their health systems. And hopefully some of the presentations will allude to that today. So our first presentation that we're going to have is Professor Quinette Lowe. And Quinette is at the University of Stellenbosch. She is the executive head of the Department of Health and Rehabilitation Sciences, and she holds a SACHI Tier 1 Chair of Innovation Rehabilitation and is an NRFB rated scientist. She is doing groundbreaking work in using the ICF in mapping functioning to the burden of disease, as well as she has doing other work on the continent related to assistive devices. So welcome, Quinette, and you may start your presentation.
Thank you, Sraya, for the introduction as well as the invitation. I just want to make sure that I do have the sound.
We hear you.
Okay, great. Thank you. Good afternoon, colleagues. It's a great opportunity for me to present some of the work that we do in this domain. And as we celebrate the 25 years of the ICF, I would also like to share some of the conceptual work and the practical tools that we have conceptualized to strengthen rehabilitation within the health system through the development of, specifically today, an application that we call Rehab for All, a functioning profiler. So the motivation for the Rehab for All arose from a very simple observation. And that is that we, as well as health systems, are very good at counting disease. And we have notable global databases, such as the GBD that we trust. But we are less effective in measuring the consequences of disease on functioning, which is more pertinent for rehabilitation. We know how many people have a stroke, have diabetes, have arthritis, or HIV, but we cannot answer a very important question specifically for rehabilitation, and that is, what difficulties do individuals experience in their daily lives, and what rehabilitation services should be prioritized to address them within a local context. So the ICF framework provides the optimal option to answer this specific question because it shifts our focus from disease or diagnosis to functioning. And despite its global acceptance, operationalizing the ICF has remained very challenging, not just at a national level, but also globally. Oops. Yeah, I'm gonna move. There we go. So this conceptual idea led us to develop what we today call the Rehab for All application. And the Rehab for All application centers on three core principles. So the first is that it is a data-informed system to strengthen rehabilitation across all levels of the healthcare system, because rehabilitation planning, we believe, should be informed by all available local evidence. Secondly, we have embraced a shift from a disease first to a functioning first perspective. And you can thus understand why the ICF framework has been central to this specific work that we do. Thirdly, the synthesis of the data is at population or national level, and it's specifically on the burden of functioning or the functioning burden to support rehabilitation planning, workforce development, policy decisions, and investment, and provides a much better estimate for rehabilitation services as opposed to disease-specific databases such as the global burden of disease. And this very complicated slide illustrates how we moved from a disease-centered to a functioning-centered perspective. We operationalized the ICF by translating disease-based evidence, starting with a GBD profile of each specific country into a profile of functioning burden of a specific country. And we begin by understanding or identifying the conditions that contribute most to the years lived with disabilities. So we start with the GBD database, and then we identify the functioning problems linked to each of those conditions. And because because each disease may have multiple functioning problems, it actually explodes into an interconnected functioning tree, because each functioning problem will also have multiple ICF classification domains. And the resulting dataset allows us to aggregate and compare functioning burden across conditions, not just within a specific condition. It generates country-specific profiles based on weighted pool averages of prevalence estimates and all other ICF related outputs that we will demonstrate to you. And it can be used then to inform rehabilitation planning or policy. And then in practice, it is a bespoke application that we have developed specifically for this purpose. And with that in mind, we have ensured that the process is very efficient. So we start by collecting the available evidence, extracting and then structuring the functioning data. And all of this to add at least one data source takes us approximately 5 minutes. And then all this information is classified and mapped to the ICF. The platform is then automatically aggregates and synthesizes the evidence across conditions, producing country-specific profiles of the burden, priority needs, and highlighting service as well as research gaps that can support planning and decision-making. And this slide just illustrates the landing page of our publicly available dashboard where you can access this information. And it also states to date that we have included 1,156 articles. We have included all African countries, but only have data on 41 countries, and the other countries have no data available, and it's not because they have not been reviewed by us. And it's close or just over 400,000 individuals. And it includes 3,292 domains up to today. And this is one of our recent papers on some of the aggregated data that we have published in April this year. And to our knowledge, this is the first continent-wide application of an ICF-based approach to quantify the functioning burden. And here we've literally put Africa on the map. So our vision was to map the entire Africa. As I said, we've only had data on 41 countries. But these maps, which is included in the paper, it illustrates the power from a functioning perspective, because we can identify and compare the dominant functioning of ICF categories across countries and provide a new lens through which we understand rehabilitation needs and priorities. But what became immediately very apparent to us is that functioning problems rarely occur in isolation. Individuals do not simply experience mobility or communication or pain. Instead, functioning challenges cluster around body functions, activities, participation, and environmental domains. This network analysis included in the paper shows that the complexity and reinforces the need for comprehensive and integrated rehabilitation approaches rather than condition-specific or profession-specific solutions or strategies. The Rehab for All is now up to date, has up-to-date data up to April this year. And we would like to just play a short demonstration video so that you can see the dashboard that we have developed. Kindly let me know, hopefully the sound works.
The Rehab for All Functioning Profiler is an interactive evidence platform designed to summarize and explore functioning problems across health conditions and settings. At a glance, the homepage presents key metrics from the evidence base, users with an immediate overview of the breadth and scale of the available evidence. The overview dashboard summarizes the characteristics of the included studies, including study setting, study design, and health condition. The dashboard is fully interactive. Clicking on any just primary health care under care level automatically filters all to display the corresponding characteristics. The article search dashboard provides a searchable index of all studies included in the review. The dashboard includes multiple filters and a summary counter that displays the total number of articles that meet the selected criteria. Users can refine the evidence by the different study and population sample characteristics. The dashboard also provides detailed information about the underlying evidence, including the author, publication year, and study title, with each title presented as an active hyperlink, allowing users to review the original article in a new browser tab, enhancing the transparency and reproducibility of the mapping process. This function also appears on the Functioning Profiler and ICF mapping dashboards. The Functioning Profiler provides an overview of the functioning problems using broad categories. For each problem, users can see the number of studies, sample size, number of people affected, and the prevalence. Users can drill down from a broad category, such as mobility problems, to more specific subproblems that reflect how individuals are most likely to describe their difficulties to a healthcare provider. The dashboard can be additionally filtered by a minimum number of articles or participants, enabling users to focus on the most relevant evidence for a particular population. The ICF domains dashboard shows how the evidence is distributed across the ICF domains based on the number of studies reporting each functioning problem. Results can be displayed as a radar plot or color-coded bar chart with colors representing the ICF components. Filters allow comparison by country, gender, and health condition. The ICF mapping dashboard demonstrates how functioning problems identified in the literature are mapped to the ICF framework. When a functioning problem is selected from the panel on the left, for example, communication problems, the dashboard displays all corresponding ICF components, domains, and specific ICF categories to which the reported problems were mapped. Where studies provided more information, the relevant ICF subcategories or qualifiers are also displayed. This page also demonstrates how seemingly broad problems can encompass multiple ICF domains and categories, reflecting the multidimensional nature of human functioning. The Prevalence tab shows the temporal trends in the prevalence of functioning problems reported across studies between 2006 and 2025. You can select one functioning problem or use the control function to select multiple related problems simultaneously. The interactive world map displays the prevalence of selected functioning problems by country based on eligible studies included in the review. The size of each marker is proportional to the reported prevalence, providing a visual indication of the relative burden of the problem within that country. Users can select a single functioning problem or select multiple functioning problems simultaneously using the control function, which displays the markers as pie charts, with each segment representing a different functioning problem. Countries without eligible studies for the selected problem are not displayed, illustrating important evidence gaps across the continent. Together, these dashboards provide an integrated, evidence-based view of functioning that can inform rehabilitation research, policy, and service planning across diverse health conditions and settings.
Oops. So, colleagues, we believe that our Rehab for All platform combines the scientific rigor of the ICF as well as the efficiency of a digital platform. It leverages on locally available evidence. It's user-friendly and was specifically designed for resource-constrained settings where rehabilitation is often limited or lacking. In conclusion, and 20 years after the introduction of the ICF, the Rehab for All demonstrates how this framework can move beyond classification and become a practical decision support tool, generating functioning intelligence to strengthen rehabilitation systems, research, policy, and investment. We would like to, of course, acknowledge our funders, Stellenbosch University and the National Research Foundation, as well as my co-presenter, Maria Sharambura, who has walked with Journey with me, and other researchers in my research team. Thank you very much, Chair.
Thank you, Quinette. I think that was a wonderful presentation and an opening as to what the capabilities of the ICF actually is. I'm going to open just for 5 minutes if there are any brief questions or points of clarification to Quinette. Please just put your hand, raise your hand, and if you have any questions or points of clarification. Oh, we do have one hand. Warwick, you can go ahead.
Sorry, just had to be unmuted. Thanks so much. No, thank you very, very much for that presentation. To somebody who is really a novice on ICF, that was really eye-opening, and so mine's more of a comment. I mean, obviously there are lots of questions that can flow, but really just to thank you for that, and yeah, certainly was extremely valuable for somebody who doesn't know a lot about ICF and has learnt really a lot from one presentation, just how powerful and what can be done. And yeah, congratulations to all of you.
Thank you, Warwick. Joe, do you have a question? You can go ahead.
Hello.
Yes, I hear you, Joe. You can go ahead.
Hello.
Yes, do you have a question for?
Yeah. Okay.
Go ahead. Please do go ahead.
All right. Okay. Thank you so much. And I think I just want to appreciate the efforts that have been made so far. I think the one thing that we really have to know, and I should concur with your presentation, is that the systems of classification, the ICD, is it ICD 11 that we have been using, I think we really have been having some difficulties in terms of like classifications of diseases when we are dealing with functionality. Yes, indeed, that one is the system that we use focuses on like disease specific. But then when you look beyond that, we look that there's really quite a big gap in terms of like or assessing or classification according to functionality. I read about the ICF, Warren College, but after that, despite being in the policy making field for quite some time, I really have never thought of this approach of using the ICF in classification more than this. So I think this is quite a good development, I should say. Like like from Malawi, Minister of Health, where I'm working as the head of medical rehabilitation department, this is quite a good thing that the recognition so far is now coming. Thank you so much, and I really welcome this development. Thanks.
Thank you very much for that comment. But also, as you should know, that the ICD 11 has a V chapter that includes ICF functioning domains. So if you are moving into the use of the ICD 11. Thank you, Quinette. We are going to move into our next speaker. And our next speaker is Dr. Jonathan O'Dear, and his presentation is going to focus on, and I apologize, Dr. Nadir, you did give us the new title of your presentation. That's not included in the agenda, but this is moving from pedagogy to the implementation of ICF at primary care level. So Dr. Nadir is a specialist physician and co-lead in the Department of Medicine at the Mitchells Plain District Hospital, and he combines his frontline clinical care with digital innovation to improve how health systems work, and is passionate about using technology to better integrate the different elements of care. So his work focuses on building practical, data-driven solutions that enhance patient flow and strengthen referral pathways. Thank you, Jonathan. You may go ahead.
Thanks so much. Really appreciate it. And I think Isaac Newton said, I can see further now because I've stood on the shoulders of giants, and basically half of my presentation has been done already. But as a hospitalist based at Mitchells Plain District Hospital, I care for acutely ill patients. And as such, I live in the world of ICD, focus on disease, diagnosis, and conditions. But the reality is there's another world out there that focuses on the lived experience of a patient, the interaction between themselves and their families and individuals and the environments. Though this is the same patient, their experience and our focus differs greatly. And this is where I'm so grateful for the introduction to ICF just over 6 months ago. And I think I can echo what Warwick says. I'm a novice to ICF, but it really poses so much for our future and understanding where we can move forward from here. Why does ICF matter in primary care? Well, the reality is we need to move away from the disease that a patient has to actually the impact this has in functioning in daily life. And if we don't focus on those 4 areas, we actually are not serving our patient. We are just serving ourselves in diagnosing and giving treatment to disease. I'm going to very briefly talk about a project that we are shortly going to launch in Bishop Lavis, which is a community health center based in an impoverished community here in Cape Town. As a facility, it serves as an undergraduate training site for students from Stellenbosch, University of Cape Town, Cape Peninsula University of Technology, and is a Western Cape government direct service site. And as you can imagine, how do you put so many different students from so many different tertiary facilities into one health system and actually have a meaningful flow of information? And ideally, what we're aiming at doing with our project at Bishop Lavis is, can we facilitate the flow of information, not only to inform teaching, but also to help the health system understand and move forward? And so what we're doing at Bishop Lavis is we are moving to see what can be done with creating a digital system that creates transparency of data that can be used. This is a summary of the system that we are looking to trial for this period of time. And the development is well advanced, and we are very excited for actually collecting data for the system. But I think the key thing that is really important is it's about keeping the flow of information through different parts. I'm not going to speak at length to this slide, but I think the important thing to know is we need to facilitate movement of information between multiple role players to assist our patients. One of the key focuses of the system is how do we capture patient information so that it is available for future students in the event of the medical record not being available. And whilst we await with eagerness an electronic health record, this will give us some really valuable insights. The students on review of a patient will capture some granular details related to that patient using existing tools within the Western Cape Department of Health and Wellness. In this case, we are using an MS form that these details are captured and stored in a POPIA compliant site. They then make a working diagnosis, assess their subjective, objective, action, and plan. But most importantly, what we've integrated into this is a ICF coding step, where at the very least they need to provide 3 ICF codes for their patient. However, and on completion and submission, this is a digital output that is automatically created, saved in a central database, and the referring clinician receives an update of the event for the patient that they referred. The challenge you can imagine as a student in their 2nd or 3rd year, though they have had some training in the use of ICF, how do they go about finding the correct code? Do we want to limit them to core sets, or do we actually want to look at the full expanded data set? And as such, we've developed a very brief natural language model that serves as a teaching tool for these students. It doesn't replace judgment. It supports their learning. It reduces classification complexity for the student, guiding them in understanding and focusing on the patient's story. And the idea is really to be interactive, making the ICF a tool that you can engage with, communicate, and look at. Essentially, what we've done is we've taken the code values from ICF and uploaded it as a single file into an agent. In this case, we are using Notebook LM. That agent can only use those codes in the discussion with the patient. Here you can see that what might be a relatively junior student has expressed that they have a patient with hearing impairment from otitis media, and the key impact is they are unable to communicate effectively with their children. They framed it, what are the codes that I might consider in this case? And then there's a very brief feedback that comes through the process that identifies the necessary codes, gives them a selection of codes that might be able to use in this case. You can see the output here. They might then be able to proceed and follow that up with a bit of a discussion and communication regarding structures. Maybe they're not aware of the structures implied. Why this training wheels approach is important is it's to support in resource limited settings when necessarily the amount of supervision is not what we would like or desire in this scenario. It suggests possible codes, but it helps and prompts them for missing factors, and it encourages reflection for the students. It's really useful that it justifies, it gives a bit of background why that code was chosen, and that helps the person to develop their clinical reasoning. Because it's a sandbox setting, it's a safe to fail learning environment for them really to experiment and look at things. However, now that this data is being captured, we don't only move from what are the codes that are being captured, but now that we can capture those codes, that can be meaningful in real-time data. And very similar to what has been displayed and shown for yourselves on the screen, we can capture those ICF codes, which we then reference against the gold standard ICF to make sure that there's no erroneous codes that have been captured. And this creates a real-time output at a facility level for each discipline, as well as related to their ICD 10 or 11 code. In this case, you can see that we have selected physiotherapy as a discipline to understand the codes that they've chosen. Please note, this is only testing data, so it's very much dummy data to check our system is ready for actual implementation. But in real time, we'll see that physiotherapists are using D450 as the most predominant code that they're using out of all of the codes that they are expressing. You can see that mobility is the biggest domain of 28% for physiotherapists. We're also able to map these data to actual ICD-10 diagnoses that are captured for the patients. So with patients with a diagnosis of diabetes mellitus, we can see how our physiotherapy and occupational therapy teams map different sections of code in regards to domain, but how the engagements also differ. This will be very useful data for us moving forward to understand the needs in our communities and for us to be responsive in resourcing in these communities. The key element is real-time reporting that we can see exactly what's happening. And it really builds on a lot of that foundational work that we've seen where research data has been used to understand what's happening in geographic settings. So thank you so much for your time. We really appreciate everything and the ears that you've given. 25 years since its inception, the ICF remains highly relevant. And there are some new tools that might help us unlock its practical use for the next generation of primary care professionals. Thank you very much, and I'm happy to take any questions.
Thank you so much, Jonathan, for that practical implementation of ICF. I open now for some questions to Jonathan. If there are any, please do, as I said, raise your hand so that you may be identified. Okay. Oh, Ragini, go ahead.
Hi, thanks, Sarah. Thanks for that. Thanks, Jonathan. So I'm very much aware of Jonathan's work in terms of our referral SWAY and e-referral forms, which he helped design and implement in terms of our referrals. Jonathan, I just wanted to know, I know you're doing this at Bishop Lavis. Are you piloting it perhaps anywhere else with us? Because I think this would be a great way for clinicians just to start getting the hang of using ICF more on a practical day-to-day basis, because I can tell you now the clinicians are very anti-ICF in terms of it's extra work. You know, it's going to take me too long. And I think if we can just get clinicians just to start doing it, using it, it's going to be so great. And what you just presented made it look so simple. But you know how much of data we'd be able to get out of it. I mean, it's going to help us significantly. So what you presented was really great, because it was very simple, but the power that comes with that information, the evidence and the research that we can extrapolate from that is going to be great. So I'm really hoping you're going to do it with us as well. Thank you.
Thanks, Ragini. Do you have a response, Jonathan?
The system has been designed to be readily scalable and accessible to anyone. We've intentionally not used agents in certain environments that restricts access. And so pretty much the sharing of using the tool to explore and understand coding, or the different codes, can be readily shared with anyone. I definitely think there's certain environments, and the work that we've done at Krudiskia lends itself to immediate implementation.
Thank you, Jonathan. Stephanus, a quick question.
No, just congratulate Jonathan. Nice to meet you. I've heard so much about you, and it's exciting to see the work that you are doing there. You know, I think back about 10, 15 years ago when we've tried to do that at Bishop Lavis, and it was just a brick wall. But it's fantastic to see that things are changing and that people are more and more open to use ICF as they've used it on the Aquanda platform across the mountain. We've done some research before. So yeah, congratulations.
Thank you. We will have another Q&A session later on the program. Quinette, do you want to hold over, or do you have a quick question?
No, just Rugini, and to add to Jonathan. So at the moment, we're looking at about 7 primary care facilities. But importantly, I think she said, you know, how the therapists think it's such hard work. And accompanying this process moving forward is actually a lot of implementation work, Rugini, to work with a therapist and the other referrers to understand what are the barriers, facilitators, and then even make adaptations as we move along. Because we agree with you that the culture of data entry should be changed. Thanks, Raya.
Thank you. And that takes us into our next presentation, where we have Nenad Konstanchek from the WHO. Nenad has been working in the Classifications and Terminologies Unit at the World Health Organization in Geneva since 1999. He was responsible for the international field testing of the ICD-11 and the development of the traditional medicine chapter within the ICD-11. He is overseeing the modernization of ICF and the development of the traditional medicine chapter and code sets within ICHI and other classifications. Nenad will show us how it will make clinicians work a lot more easier with a demonstration of the ICF coding tool. Yes, so welcome, Nenad. You may start your presentation.
Thank you very much, Thoraya. And well, first of all, I would like to express the gratitude and also for kicking off the birthday celebrations for the 25th anniversary on ICF. That is really very nice to see the lineup of, I would say, state-of-the-art birthday presents, which Quinette and Jonathan, and I'm sure also Michelle and Stefanos are going to present. And so we will make sure that we put this under the birthday tree when we have the bigger celebration in the upcoming FIC meeting in Australia. I think for this brief presentation, I would like to basically pick up where we had, started in terms of putting the elephant in the room, which is, of course, the patient, and making the lived experience, as Jonathan rightly pointed out, in terms of health, really visible and addressing it. And as we see here, we are looking at, all these different perspectives we have, whether it's from a clinical rehab perspective, whether it's from a population health perspective, AI, electronic health record, or what we see increasingly coming up in countries, the establishment and integration in health information exchange platforms, terminology servers. So at the end of the day, one really has to make sure that in order to facilitate communication, in order to ensure interoperability between these different data sources, which are all aiming to improve the health of the patient by the different professionals who are engaged, we understand each other, and there is communication, as the previous speakers also alluded to. And that is only possible if we have a kind of semantic backbone in place across the different domains of health. And this is basically what the ICF is about in terms of functioning, but making sure that it is operational in this new digital environment and in this digital transformation we are going through, and having AI on the horizon or already being implemented. So in terms of the big reason why we are moving into this new field is, and what is new in it, is that we have integrated what we call the family of international classification. So we have one foundation which is providing the semantic backbone across the different domains, whether it's disease, functioning, or interventions. And we are bringing into this all the different other resources within WHO, whether these are other classification nomenclaturas which are on the side for specific purposes, and of course also trying to link it with other external standards where this is useful and applicable, such as LOINC or Orphanet or others. And doing that, of course, means, and I think we already were, you referred to this, with the intent to really capture the full picture of health in terms of what is the health condition, what is the lived experience of the person with the health condition in terms of his or her functioning, what is done to the person in terms of interventions, including rehab or public health interventions, and what does it change in terms of functioning, which is, and this is where HUDAS comes into the picture as a health outcome measure. Now, looking at the infrastructure we had in the past, I just put here contrasting the old ICF browser with the new ICF browser. And what you see here is basically that we had this taxonomy of 1,000, almost 500 functioning domains, codes. And within that, we had definitions. And as you can see here in this example of the state of consciousness, you see that there were some narrower terms or subtypes which we could consider as consciousness, stupor, coma. So sometimes these are narrow terms, sometimes they're synonyms, but you could not really find them. So they were kept in the definition, but not searchable. So talking about making it user-friendly, clinician-friendly, reducing the burden of documentation and coding, and that was not a very good solution. So what we are doing and did already, but we are continuing to do so, is to basically develop a kind of underlying terminology layer within the ICF in a similar way it has been done for the ICD-11 by, for example, in this case, identifying what are the related impairments in this definition and making them part of the index so that they become searchable. Like in this case, clouding, coma, and stupor are now index terms. Now you see here an overview of what the architecture and the content model in very simple terms looks like, and how does it contrast with the old book version and the browser version we had back in 2017. So you see that many properties are still there, but they are rendered in a different way, or they were not there at all. So in the interest of time, I will not go through all of them, but just perhaps proceed with the practical visualization of what this means in terms of the end user tools. But there is a fundamental difference between what we call the foundation, which is the big repository of all the different terms where we don't find codes, and then the linearization, where you also apply classification principles, like, for example, residual categories. But what matters is really that we look at the end, what is the interaction, what does it mean for the user? And the key point there is that it should be as user-friendly as possible. So when you type in, for example, now coma, you get to the correct code within an instance, and you don't even do this, need to do this as a person. You can do it also in an automated fashion by using certain tools. So it is basically a process which can be completely automated by using the coding tool. Another example, and this is very fundamental to really understand the, let's say, architecture, the information model, the new language we're also using to render ICF, is captured here in this slide. So you see a codable entity. I put here the example of play, which carries a code. But underneath, you see the index terms, and this can mean that you have synonyms, like in this case, play or playing, the noun or the verb. And you will see this repeatedly in some of the other domains as well. And you have what we call subtypes, which might be not as important to give a code to it, but nevertheless, they are important, particularly from a clinical or rehab perspective. And in this case, these subtypes of, for example, solitary, palliative, or onlooker play came from the ICF-CY, so they were brought in, and they are now searchable. You can code them. They are linked to the higher level category, so you have it in your data set. And in order to ensure this, you have here the reference to the unique identifier, the URI. And it's very important for the future that in any kind of electronic digital application, you make sure that this URI is basically stored at the back end. And last but not least, as we all know, the ICF domain or entity is not complete unless we have a qualifier assigned to it. And that is also now enabled through the tooling environment, through the coding tool. And here you see rendering of this particular example of solitary play in different language versions. We have now 10 language versions of the ICF in this kind of new rendering available. You see here next to English, French, Spanish, Chinese, and the Turkish version. What is also important to highlight is the fact that, as I said before, we can add through post-coordination the qualifier, whether it's capacity or performance, to the code. In this case, it is done through manual post-coordination, so it is really by clicking on the plus sign, you add it in a manual way, but we have it also automated, and that is something we are using extensively also for ICD or for ICI, and increasingly, I mean, this is work in progress as we refine the tooling environment, and you see here how this would look like if you add in this dynamic search, for example, the term moderate, and then it gives you automatically the options to either choose the performance, the difficulty in performance, difficulty in capacity and performance, or in capacity, depending on the use case. And you can select this. Now, what really will be important is to make sure that in practice, these kind of new features are leveraged. I put here rather old, I think, old-style software from one of the hospitals here in Switzerland on the screen, where you see how the ICF is used primarily as a conceptual and terminology. So you see here for rehabilitation goal setting, the specific targets or sub-targets. They also indicate the severity status, the prognosis by discharge, and then you have comments and by different providers, whether these are PTs, OTs, or long-term care staff. Now, here you see that there is a kind of drop-down list which is used, or simple text search. And of course, it will be very important to make sure that the integration of these new features is embedded in these kind of electronic applications, whether these are rehabilitation records or more sophisticated terminology servers. And that is definitely something which is coming up in a very strong manner. You see here also the reporting sheet. And I think this brings me to something which we have earlier seen in the presentation by Quinette. One of the key features of the ICF as for ICD or ICI is the fact that you can aggregate the information from a very detailed entity or concept to the higher level categories. And for reporting purpose, of course, you want to do this. You don't see this at this point done in this particular rehab reporting. So the data basically remains there at the individual level in this data silo. And I think that is something which will be very important to look into the future when we are talking about the tooling infrastructure and to develop it from an ICF perspective. Regarding the lower right part here, we have tabulation lists for mortality morbidity data. We should have also tabulation lists for functioning data. So it will be important to really pay and look into how this can be addressed. And it is something which the FDRG is also going to work on. But apart from that, I think the key message here is that with the new environment, we are not only looking at rendering some of these tools like the coding tool, but the whole tool suite for different purposes. We have now a training or coding training tool which is used extensively for ICD, which is also can operate for ICF, the ICD Fit platform, where you can do this kind of coding exercises as I just demonstrated with terms or with case vignettes. We have a tool which is called Code Fusion for automated term mapping from any kind of data source into ICD, ICF, or ICI. The translations are done in ICF on the new multilingual translation platform, and of course there is a proposal platform. And in future there will be more. One of the, I think, key new tools which we are working on, and we just completed a workshop a week ago or 2 weeks ago with the HL7 FIRE community on releasing ICD APIs, and these are including also ICF APIs, because we see in a number of countries that as they are integrating or building up terminology servers for the countries or even at sub or regional level for information, health data information exchange, they want to embed in this also ICF for functioning purposes. So that's why having FIRE endpoints part of the APIs is becoming very, very important. But the other highlight, of course, is the fact that these offline deployments are also provided. You see here the current language versions of the ICF. This year, as I said, we have 10 languages, and we expect that by next year quite a number will follow. I think South Korea is also here on the call with Haijung, so we look forward, for example, to have the Korean version here also then rendered officially. We have from now on, over the last 2 years, annual release cycles for the ICF in the same way we have it for ICD, and the same will apply for ICI. So that is the new modus operandi. And I think compared to what we had in the past, where all these updates were manually created, now they are automated, and there's automated curation, which makes it very, very easy to incorporate the updates as compared to what we had before. And last but not least, just an overview on the value proposition, and that applies for all the classifications we have in terms of really making it clinician-friendly, user-friendly, so that the coding exercise per se becomes fast, accurate, and simple as much as possible. It is all done in a digital environment, so the idea of just disseminating the book is passé. We, of course, want to have natural language processing capacity in ICF. We are starting or in the process of doing that. This is not as sophisticated, as completed as you have it now in the ICD-11, but we hope that through the collaboration we have with the collaborating centers and with countries and the data which can be harnessed for this purpose, we can catch up so that the ICF will be not only celebrated in the last 25 years or for many, many years to come. And last but not least, very important as well, is that with ICF we have a classification and terminology which has cross-cultural applicability. As a global public good, unlike some other proprietary system, it is freely available. There's no license fee or other costs attached to it. And that is something which I think is very important to leverage as well. With that, I thank you very much. I'm looking forward to any questions or comments. Thank you.
Thank you, Nenad. I think that highlights the use of the ICF and how easier it can be now that we have a digital environment for the ICF, and also the availability to countries. I'm just going to open up for one question because we're already over time in terms of your presentation. Any questions or comments to Nenad? Also to say that we do have a Q&A session later in the program if you want to give some thought to the presentations that have happened so far and how they relate to the implementation of ICF in the country, and especially on the clinical setting. Just moving forward now, we're going to just shift gear a little bit in terms of ICF and clinical use, but also understanding that all of what we've heard now is quite a mouthful. And I think Ragini also alluded to it, that it needs education and it needs training. So I'm now going to invite Dr. Stefanus Snyman to do his presentation on education in terms of the ICF. Stephanus is associated with the WFIC Collaborating Centre in South Africa and is being a member of the FDRG, which is the Functioning and Disability Reference Group of the WHO, since 2012, and served 2 terms at its secretariat. He is a founder and board member of the ICF Education Portal and a coach on the ICF Facilitators course, which is jointly presented by the WFIC, South Africa, Netherlands, South Korea, and Australia. Welcome, Stephanus. You are muted, Stephanus. Still muted.
Stephanus, can you try unmuting on your side? It says that you can. You're a participant and you should be able to unmute. Hi. Okay, sure. Sorry, Stephanus is having some tech issues. He just needs to rejoin the meeting. So can we go ahead with Michelle, please?
Okay.
I hope that's okay, Michelle.
Hi, sure, yes, no problem.
Okay, then I shall introduce Michelle. Dr. Michelle Janse van Rensburg is an occupational therapist, and she holds a master's in public health from Wits University and a PhD in family medicine from the University of Pretoria. She has extensive experience in under-resourced community settings since the mid-90s and transitioned to academia in 2003. Michelle serves as a senior lecturer in occupational therapy at Wits, and she will be presenting on the use of the ICF in curriculum development within occupational therapy. So welcome, Michelle.
Thank you so much. Thank you, everybody. So I'd just like to share a little bit with you about how we're using the ICF as a framework for recurriculating our occupational therapy program at Wits University. So what happens when you try to build a whole curriculum on the ICF? So before I start, I would like to express my thanks to the ICF Education Facilitators course, which Stephanus will talk about. It's presented by the WFIC Collaborating Centres in South Africa and the Netherlands. And so a particular thanks to Stephanus Snyman, Huub ten Napel, Catherine Sykes, and Hajian Lee for their contributions to this program and from whom I've learned so much. So why recurriculate? The driver is national health insurance, at least in South Africa. And South Africa's move towards universal health coverage will require ICF-based reporting of functioning across every health profession. The implication for us as educators is stark. Graduates who cannot work in ICF language risk being invisible in interprofessional teams and invisible in how health services are financed. There's a mandate too. Let me just go back there. The World Federation of Occupational Therapists built the ICF into its minimum education standards back in 2016. So ICF literacy is already a graduate competency, even though there are concerns internationally about classifying people and nationally regarding scope creep within the profession. So this creates a tension that we have to hold really carefully. We need graduates who are fluent in ICF language, but not at the cost of the professional reasoning that makes occupational therapy a distinct profession. So our answer is that the frameworks are layered, and are not competing. So the ICF, as we see it, is the overarching framework and the shared health system language. The Occupational Therapy Practice Framework, which is currently in its 4th edition, is our professional domain map and is already aligned with the ICF. The model of human occupation is the theoretical engine explaining why people engage in occupation or participate in life. And the Wona du Toit model of creative ability is our therapeutic mechanism as occupational therapists, grounding us in a South African knowledge tradition.
So the ICF gives us a biopsychosocial spiritual frame, and we're using Stefanus's framework, framing around that, that holds all of these. So these are the models that we use in our occupational therapy undergrad training. So as I mentioned, the occupational therapy practice framework is our framework that guides everything we do. And it's really the essence of what we do is achieving health, well-being, and participation in life through engagement in occupation. The model of human occupation provides us with an understanding of volition, habituation, performance skills within the context of the environment. As I mentioned, the Bono du Toit model of creative ability gives us an understanding of the person and how their volition guides their action. And all of this is seated within community-based rehabilitation through the CBR matrix. In order to do our curriculum and our recurriculating rigorously rather than intuitively, we've been using Kern's 6-step model for curriculum development. So it takes us from establishing governance and a clear mandate through a needs assessment, defining the gap between our current graduates and what the novice practitioner in the public health system actually needs, into defining outcomes through competencies and entrustable professional activities, and then into curriculum architecture, assessment, implementation, and quality improvement. And the ICF threads through all of these steps. We're currently between step 2 and 3 in our process. As part of our process, we then, all as a department, all our colleagues in our department participated in the ICF education facilitators course, and we were all able to learn and ground ourselves in the ICF. And so it becomes the conceptual heart of the work that we did. So we've mapped our profession and our professional frameworks onto the biopsychosocial spiritual rendering of the ICF. And so if we start with activities and participation, we see how the occupational therapy practice framework and the occupations and performance patterns, our habits, our roles, routines, and rituals all make sense in line of activities and participation in the ICF. We also see how, when looking at ICF body functions and structures, together with values, beliefs, and spirituality, our occupational therapy practice framework, our Bono du Toit model of creative ability, and our model of human occupation in terms of performance skills make sense in relation to body functions and structures. In terms of the environmental factors, the OTPF, the Occupational Therapy Practice Framework, does speak about context, and the MOHO speaks about the environment. And then again, the Bono du Toit model of creative ability and the OTPF helps us to make sense of the personal factors. And so, putting the whole picture together, we see functioning in context. And that is the phrase that we want every graduate to carry. The ICF lets us name it, and our OT practice frameworks and models let us explain it. So as part of our ICF education engagement was working towards projects that then would support us in our recurriculation endeavors. And so we have 6 very clear projects that came out of the ICF facilitators course, which I'll briefly go through with you, which kind of culminate into a framework that synthesizes the occupational therapy practice framework and the ICF. In terms of the overlaps, divergences, and gaps, and designing an ICF-based occupational therapy conceptual framework. So we've also mapped the model of human occupation onto the ICF. We've looked at our public health and community-based rehabilitation teaching, our pediatric curriculum, and developed an ICF-informed marking rubric, as well as a really interesting project around dealing with student anxiety in fieldwork with an ICF-based toolkit that supports students. And these all then work towards work that our Occupational Therapy Association of South Africa is doing towards standard operating procedures that are based on the ICF. When we look at entrustable professional activities, I just want to mention that competencies describe qualities of a professional, but EPAs describe units of work that integrate multiple competencies and can be entrusted to students to demonstrate their readiness. And so as a department, we have articulated 9 entrustable professional activities or units of work that we want to be able to trust a graduate from Wits University to be able to perform. And so you'll recognize the ICF in them immediately. EPA 2 targets participation. EPA 4 is all around environmental modification. EPA 7 is documenting and reporting in ICF terms. So we wrote these using Tenkata's methodology around EPAs. And they are really how an abstract framework that we've developed actually becomes something accessible in our curriculum work. So here's an attempt to bridge all of this, where each EPA maps onto an ICF role or domain and onto an occupational therapy pillar that gives its depth. The pattern running across these is that students reason internally using the occupational therapy frameworks and the ICF, and then report outwardly using the ICF language. The conceptual framework that then we've developed as a department underpins all of these 9 EPAs, while the projects that I've told you about will build the machinery for the effective expression of those EPAs. All right, so here briefly is just an example of some of these projects' detail. So I just need to find my notes. One of the projects was to map, the MOHA onto the ICF, concept by concept, and producing ultimately a CPD short course so that practitioners can keep their reasoning while gaining ICF fluency. And so we're quite excited about building this into a short course or CPD course. Another project was, as I mentioned, was aligning the public health and community-based rehab fieldwork to the ICF. And what this did was foreground the environment and participation, which was really very helpful. And so a whole model was developed around how to integrate the ICF, the CBR monitoring manual and menu, the WHO rehabilitation competency framework, and the CBR guidelines into the module and expressing the learning outcomes accordingly. The third project that I am highlighting is the pediatric curriculum, which was built around the CAN Child F words and the life wheel as a child and family-friendly way into the ICF, scaffolded across the 4 years of the occupational therapy program. And so this assisted the colleagues working on this project to articulate year-by-year learning objectives and ready-made teaching resources that would include the F words and the life wheel outcomes tool and the HUDAS 2.0 child and youth assessment. The fourth project was around developing a new case presentation rubric that would replace our very segmented physical and psychiatry case presentation marking rubrics that we've inherited over years. And so this really shifts students away from the biomedical model, and is an example of this is shown here. The fifth project was supporting students, as I mentioned, who become anxious in fieldwork, and it disrupts their own occupational performance. And so this toolkit was able to map students' anxiety using to ICF codes, and thus treat that anxiety as a work-related problem and not just a mental health one.
Time, Michelle.
Thank you. I'm almost done. All right, and so the next project was our actual conceptual framework that our head of department developed, which has been very helpful in aligning all the work we're doing to recurriculate. And so really, the ICF is not a compliance tool bolted on, but it's the structural spine. In the environment, the ICF gives us the E codes, and MOHO adds to the occupational environment. In body functions, the B and S codes align directly with the OTPF client factors, and the MOHO adds the lived felt body. For the person, the ICF acknowledges personal factors but deliberately doesn't classify them, and that's exactly the space that occupational therapy fills, with volition, habits, roles, identity, and meaning. And in activities and participation, the ICF gives us the observable qualifier scale, while our framework explains why performance happens and what it means. Without this, we have theoretically deep graduates who are ICF invisible. With the ICF embedded in our curriculum, we have ICF fluent graduates ready for NHI, whose OT reasoning is preserved but now translatable, who are visible in teams and in health records, and whose professional identity is strengthened rather than diluted. And this all works towards understanding how occupational therapy contributes into the universal healthcare, expressing occupational therapy contributions through the ICHI. And so there's some templates that have been developed through ATASA, which we are very grateful for. So yes, functioning as the third health indicator, functioning in context, and that is what underscores what we're doing and why we're doing it. Thank you.
Thank you so much, Michelle, and I apologize that I needed to rush you on the last few slides, but I think you've captured quite well the importance of training in ICF and why our graduates need to understand the conceptual framework and actually its implementation. Yes, so now we're going to hand over to Stephanus. That's going to give us a brief talk on ICF education and offerings on training.
Thank you so much. Can you hear me now?
Yes,
Sure,
we
yeah?
can. And we've already done your introduction, so you may go ahead, Stephanus.
I can run, yes. So, yeah, despite the 25 years since the ICF was published, there remain a high demand for education about the classification and, importantly, how to use it in practice. For the ICF to be effective, we must be able to apply it consistently and reliably, requiring quality teaching and learning materials. To dodge duplicating efforts, ICF collaborators have agreed to share resources via the ICF education portal, a central repository helping others to teach the practical application of the ICF. So in 2015, we launched the first version of the ICFeducation.org website. ICF educators over the years uploaded more than 300 resources. Recently, their website was moved to a new modern platform with the generous support of the Korean FIC Collaborating Center. The resources from the old website, though, must still be transferred to the new website. Previously, the FIC Collaborating Centers in South Africa and the Netherlands also contributed to the development and the maintenance of the ICF education portal. ICF educators can really help us if they can reload or for the first time share their ICF education materials to the new website. And researchers are also invited to share their research. So please provide us with feedback. This is still a work in progress. So we'd really like to improve your experience and make it really user-friendly. Once you've shared a resource, you're also able to register on the site as an ICF educator or an advisor. And to find ICF education resources, or to find research, or to access the resources, or the list of educators and advisors, you must first register on the site as a subscriber. Another exciting addition to the ICF education platform is, as Michelle mentioned, the ICF Facilitator course. The course was first built around 2007, 2008 by Joop ten Apel. Joop is also here in the meeting. Thanks, Joop. This is the the most amazing course I've ever done. So the course was presented face-to-face for about 10 years, and participants were introduced to the principles of ICF and the practical application of that. In 2018, the course was translated and updated to English. That was face-to-face workshops and training sessions were conducted across Africa, in India and South Korea. And with funding from the Besta Institute in Italy, Prof. Matilda Leonardi and her crowd, the course was revamped in 2022 to a fully online course on the ICF education platform. So the aims of the course are to deepen knowledge and insight into ICF, to solidify the understanding of core principles and the content of ICF, to explore the potential and the limitations of ICF's practical application, to demonstrate the ability to transfer required knowledge and insight to a specific area of expertise. And the teaching methods emphasize meaningful and application-oriented learning through live online discussions, readings, assignments, reflective exercises, presentations, and practical decision-making. The coaches on the team are from the Netherlands, South Africa, Australia, South Korea, and Denmark. And we also have guest speakers from around the world that join us on the course. The course fees are used to develop and maintain the ICF education portal. So here you can see the different modules in the course. It's a 6-month course. The next one starts on the 26th of October this year. So we start off by introducing ICF, among other things, in Module 2, just finding your way, getting everybody on the same page. Then coding with ICF, how to use ICF in a clinical setting, how does ICF fit in with the rest of the FIC family, and some practical exercises doing that. Then how can you work together in a team and use the ICF as a catalyst. A very fascinating module on ethics and human rights and making it a lot of fun. The measuring instruments and ICF. And then there are also 3 on data collection, 3 electives, and the last one is on data application. One of the outcomes, or the outcomes of the course, we've conducted 10 online courses so far, with 129 participants from 25 countries. There you can see a list of some of the countries that attended. Most of the professionals attending was allied health professionals and educators, a few nurses and administrators. So at the end of the course, you are able to demonstrate the competencies needed to develop and use ICF or functioning information by using the ICF, and to teach the knowledge, skills, and attitudes to enable colleagues or students to use ICF in their own context. Course participants present their use of ICF for a specific identified purpose where they can make a difference in their community, in what we call the final report or a final assignment. And on the icfeducation.org website, you can see on the home page, you can download just 25 projects from around the world that was born out of this course. And it's always fascinating to see what people are doing. So just a few examples. There was this, I think, groundbreaking work on interprofessional clinical guidelines for universal health coverage. Then there's this one from Croatia, a new national multidisciplinary assessment of vocational rehabilitation, plus an education program for personnel who will record the assessment. Universities from all over Europe participated in the course, helping them to develop their interprofessional education curricula. From Nigeria, electronic health records in Nigeria academic hospitals. From Cambodia, a framework to establish a child development service in a national hospital. From India, integrating a case mix model and ICF into electronic health records. enhancing stroke rehabilitation through personalized care. And then, yeah, well, Michelle already did her presentation on what the OT department at WITS did regarding the ICF. So with that, just a short snapshot of what we've been doing with ICF education around the world. You are all welcome to join the course. And yeah, it's always fascinating and exciting to see how people are applying ICF, becoming agents of change in their communities. Thanks, Soraya.
Thank you very much, Stephanus. And maybe you can just post the link to those to the 25-year booklet for participants to have access to. I think that would be great. You have a question, Ragini? Jean-Baptiste, welcome. You have a question.
Thank you very much, Soraya. And thank you, my mentor, Stefan.
Hi, Jean-Baptiste.
How are you?
Good, good. Nice to see you.
Yeah,
how's it going in Rwanda?
Yeah, I'm among those trainees for. I've seen Rwanda. Actually, it was really amazing. And to know about ICF is like when you are a religious person and you attend, you read the Bible, you know what is happening from different chapters and verses. I enjoy it as a Bible. So, so how about the ICF Education Symposium? Are they still happening? I mean, so I need that information about this.
Yeah, we've the last ICF Education Symposium, as you know, was supposed to be in Rwanda, and then the pandemic happened.
Yeah.
So yeah, we things have stalled a bit when it comes to the ICF Education Symposia. Yeah, it's really we really need to pick that up again. I think there are so many new developments around the world. I mean, just from these few presentations, I think we can really need to pick that up again. Yeah.
Thank you so much. Soraya's had to go offline for the moment. Are there any other questions for the speakers? This is now the general section. I am not seeing any hands. Last call, colleagues. Amos? Just getting you unmuted. Amos, can you unmute yourself? You should be able to unmute, Amos.
Lynn, perhaps Amos can paste his question in the chat for anyone to respond to. I see we are at time.
I also had that problem of struggling to unmute myself. I had to join the meeting again.
Yes, I think Soraya has some technical difficulties too. Apologies, everyone. I will just be handling the closing. I'm the co-head of the FIC CC and just coming in here to thank all the speakers today. And we'd also like to get your feedback on today's webinar, please. And the link to a short evaluation form will be posted in the chat. And just to mention, our next SA Community of Practice will likely be in August. But we will inform you via the mailing list. We will have an Afro COP most likely in July. And also to let you know that there's currently a late breaker call for abstracts for the 16th World Conference on Injury Prevention and Safety Promotion. I think it might be useful for those joining today in the ICF domain. The deadline is 30th of June. I can also, I just want to post the link to the late break call and the conference website. And also to let you know, as a FIC CC, we are finalizing our program to conduct an in-person workshop on capacity strengthening for ICD coding and also for ICF. It will be on the 1st of September, leading up to the main conference. I'm happy to announce that we have been successful in acquiring some funding for this, and we will circulate a call for scholarships soon to fund about 10 students or interns and those training in the clinical, public health, coding, laboratory industries to attend this workshop in person in Cape Town, and also 10 scholarships for the African region participants. So please be on the lookout for our email. And we'll add this to the pre-conference sessions on the website as well. And lastly, thank you to Soraya for chairing today's session. And once again to the invited speakers for your contribution to celebrating 25 years of the ICF. May I ask if there's any useful links for those who joined online for it to be pasted in the chat so people can follow up. Thank you, everyone, and have a wonderful
Thank
weekend.
you, Megan. Just Megan, before we close.
Sure, go ahead, Soraya.
Before we close, I know we're over time, but I just thought it's really important to mention as a moving forward with ICF in South Africa, we know that the National Department of Health through the ministry has actually published an intent for the inclusion of the ICF in the use in health systems in South Africa. So I just want Robin just to mention briefly what that actually means, and also to say that all participants are welcome. Just I will invite you to a community of practice so that we can really oversee and chat about how ICF implementation in clinical practice will happen. So really thank you to all of the speakers. I think it's given us a great background to the use of ICF currently in South Africa. And also Nina, thank you so much for giving us a background to the use of the coding tool to see that coding can be made easier now with the digital formats that we have. So Robin, if you would just like to mention in terms of the regulatory status of ICF in South Africa.
Robin's unable to unmute. Is someone able to assist?
Hang on, let me try. Just give me a second, Robin.
Okay, if he rejoins. I've tried 5 minutes to unmute myself.
Okay, Robert, maybe you can put it in the chat if we can't get you to speak. And then we had a hand from Hugh, international colleague. If you have a comment.
Has he been unmuted, Soraya?
I can't unmute.
Greetings. Hi, Soraya, may I proceed?
Okay, you may go ahead, Robert.
Thanks. Thank you. No, just to very briefly, I have put something on the chat just to briefly mention that we are formalizing and creating regulations for the family of international classification systems that includes ICF, and that what that actually then means is that we will be including ICF in our well, general clinical policies, but then also in our electronic medical records as part of our health standards. So, and quite an important point that I want to make is that as we formalize this through regulations, is that it's not about just compliance and doing things upwards towards a national department or even towards for the surveillance of WHO. With apologies to Ned, I am teasing, I always do. But we want ICF and the other classification systems to be used to solve local challenges. And really congratulations and hats off to the speakers today that demonstrated that is indeed possible and that that it is about, at the end of the day, about improving patient outcomes and supporting continuity of care. Thank you, Soraya, and thank you to the presenters.
Thank you so much, Robin. I'm not sure if Herb has been unmuted. If not, Herb, okay, you may speak.
Herb, you can just go ahead and unmute yourself. You present now.
Or quickly rejoin here.
Okay. All right. Thank you so much, Herb, and thank you everybody for joining this webinar. I'd hope to see you at the next. Have a good weekend.
Bye.
Okay. Bye-bye.
Thank you. Bye-bye.
Bye.
Yeah,
Goodbye,
bye-bye.
everyone.